Good evening, doctors. So welcome to the channel. So we shall be discussing about two very important topics tonight. One is the disseminated intravascular coagulation and the other is hemolytic uremic syndrome. So DIC, as it is more commonly known as, it is the clinical manifestation of an inappropriate widespread thrombin activation. So that means we can boil it down to one point, that is, it is thrombin activation which is happening on a widespread scale basis. Now this basically consumes all the clotting factors and platelets, hence leading to a bleeding diathesis-like situation. So this actually is a thromboembolic state in which there is excessive clotting factor consumption. There can be some very important causes which can be remembered by the mnemonic of stop making new thrombi. In the stop, it is basically 3 S's with the stop making new thrombi. So one is heat stroke, which is very important, and then is snake bites, gram-negative septicemia, trauma, obstetric complications like PPH, surgeries, acute pancreatitis, very important, malignancies, acute promyelocytic leukemia, CA pancreas. They are notoriously associated with DIC and its complications, nephrotic syndrome and transfusion syndrome. So nephrotic syndrome, basically what happens there is that a person tends to lose antithrombin 3. Now these antithrombin 3 is a protein which is lost in the urine as proteinuria, and because of the absence of antithrombin 3, there is a procoagulant state. And that procoagulant state is known to exist in a heavier degree if the serum albumin levels, it correlates with the serum albumin levels if they are less than 2.5. That means there is a correlation between low albumin levels and a procoagulant state of nephrotic syndrome. So the presentation of a patient who has DIC will be bleeding and oozing at catheter sites and mucosal surfaces, purpura fulminans, which is basically a complication of the acute promyelocytic leukemia, which is a retriform purpura, particularly at the acral sites, then petechiae, ecchymosis, altered mental status, along with hypotension and tachycardia, that is the autonomic dysfunction that comes along with that. As far as the laboratory picture is concerned, you will be able to see schistocytes in the peripheral blood smear. You obviously would have low platelet counts, increased fibrin degradation products, that is the D-dimer, low fibrinogen level because it has been consumed, and of course low factors 5 and 8 which can be measured again because they are consumed. How do you treat DIC? Basically, number one rule is to treat the underlying disorder. So one is that you treat the underlying disorder. Then, of course, you will have to provide excellent supportive care with IV fluids, platelet transfusions if the diagnosis is DIC and the platelet count is less than 10,000, particularly for those who need urgent procedure. Fresh frozen plasma is given by to compensate for the lost coagulation proteins. Now, considering heparin for any thrombosis can be considered. Complications of DIC are acute renal failure, liver injury, neurological symptoms like due to thrombi and hypoperfusion, Waterhouse-Friderichsen syndrome, which is actually adrenal insufficiency, acute adrenal insufficiency, secondary to adrenal hemorrhage or infarcts. This type of DIC is usually caused by Neisseria meningitis, in which there is Waterhouse-Friderichsen syndrome. Purpurine Fulminance, we've already discussed. It is characterized by hemorrhagic skin necrosis, often at distal sites due to thrombi and a retiform purpura. Most sensitive screening test for DIC is a fall in the platelet count. So this is a MCQ. Most sensitive. Now, most sensitive test, basically a screening test is the one which is most sensitive so that it doesn't miss out on anything which is actually there. So D-dimer is often asked in the examination. It is the most specific test for DIC. Whenever fibrin monomers, now how D-dimer becomes a specific test for DIC is when the fibrin monomers, they bind together to form a thrombus. Factor 13, it acts to bind their D domains together. Now this bond is resistant to plasmin, and thus this degradation fragment is known as the D-dimer. So D-dimer. Dimer means composed of two fibrin monomers, and because they are bound at their D domains, hence it is called a D-dimer. So never forget it. High levels of D-dimer, they indicate that factor 2A has acted on the fibrinogen to break it down to fibrin monomer, which later on are bonded together to form D-dimer. And this entirely tells you that the thrombus was lysed by the plasmin. Because the D-dimers can be elevated due to exercise, even after surgery, an elevated D-dimer needs to be interpreted definitely in the context of the clinical situation. The least specific test, now this is another MCQ. They can ask that which of the following are specific tests of DIC in the order of increasing or decreasing specificity. Then fibrinogen is the least specific, which tends to fall below normal only in severe DIC. That means a lot needs to be done before it reaches to a point of acute, low fibrinogen levels. So if we see at the questions, let's see. A 61-year-old male with a past medical history of lung cancer is hospitalized for shortness of breath. Now, lung cancer, shortness of breath, the possibilities are one, pneumothorax, or pleural effusion, which has increased to the level where it causes shortness of breath. Of course, it will be a progressive history will be there. Then, of course, pneumonia. Then, of course, there is DVT and pulmonary embolism as a paraneoplastic syndrome. During his hospitalization, so he's found to be septic. Septic means, so he has pneumonia, probably as a underlying cause of sepsis, and was oozing from his intravenous catheter site. He also develops petechiae on his shoulder and abdomen. So he's not only bleeding, he's also having petechial hemorrhages. Which of the following test results and blood smears is consistent with the diagnosis of DIC? Increased prothrombin time, increased partial thromboplastin time, decreased platelets and decreased fibrinogen 1, increased PT and PTTT and increased platelets and fibrinogen. Of course, this is not going to be the answer because there is mention of an increased platelets. Increased PT, PTT, increased platelets and fibrinogen. Again, this is not an answer. This got repeated actually. Decreased PT, decreased PTT, decreased platelets and fibrinogen. Decreased PT, PTT, increased platelets and fibrinogen. Again, increased platelets. So, nahi hoga. So the answer here is 4. The first answer. Increased PTT and decreased platelets. Yeah. So, sorry. The fourth is also not the answer. The decreased PTT. The increase in PTT and decreased platelets and fibrinogen. So the answer is increased PT and PTT with decreased platelets and fibrinogen. So they got consumed, and the prothrombin time and PTT, they got prolonged. So the patient's blood is taking longer time to coagulate. This patient's clinical presentation is consistent with DIC, which is presenting with bleeding at the cannulation sites and presence of petechial hemorrhages. And it is presenting with increased prothrombin time and PTT and decreased platelets and fibrinogen. If a PBF was mentioned in the question, they could have mentioned presence of schistocytes. Now, DIC, as we just discussed, is a consumptive coagulopathy that most often occurs in the setting of sepsis, cancers, and trauma. Common symptoms and signs include bleeding from venipuncture sites, hematuria, petechial hemorrhages, and the treatment we've already discussed. It is treat the underlying cause with, and then finally you can give fresh frozen plasma to replenish clotting factors, as well as you can give cryo and platelets. Often they need large amounts of blood products, and there is an increased risk of both bleeding and clotting, and the risk of mortality is pretty high. In the pearls, you should remember that DIC should be considered in differential diagnosis for pregnant patients with thrombocytopenia along with TTP, that is thrombotic thrombocytopenic purpura, and HELP syndrome. So these are important differentials of bleeding in a pregnant female with thrombocytopenia. These fragmented RBCs, which are also called schistocytes, they are formed because, let us say, this is a blood vessel and there is this thrombosis formed. Now we know that thrombosis is formed with fibrin strands and which are plugged by platelets here and there. So when RBCs, they try to pass through this weak thrombus, so what happens is they get fragmented. This becomes a fragmented RBC. And if you see in the PBF, you will find differently shaped RBCs, even apple core RBCs you can see. So different types of RBCs which have been eaten up, appears as if they have been eaten up, so they are known as schistocytes. So schistocytes are seen in any microangiopathic hemolytic anemias, which include DIC, hemolytic uremic syndrome, and TTP. While all three are life-threatening and management is different for each, a D-dimer can guide the diagnosis. So D-dimer is indicative of fibrinolysis. So it is elevated in DIC, whereas it will be normal or mildly elevated in TTP or HUS. So D-dimer, in its exclusivity, it can differentiate DIC from TTP and HUS. We've already discussed the diagnosis and treatment of DIC. Let's see at this question. A 65-year-old patient undergoes surgery for colorectal cancer. So see, a reference to cancer will always be there in a DIC question. Post-operatively, the patient develops intra-abdominal abscess despite the antibiotic therapy. This patient has persistent fever and develops hematemesis and melena in association with a purpuric rash. Now, the lab test shows platelet count of 70,000, prolonged prothrombin time, and decreased fibrinogen. So it is a setting of DIC. Low platelets, low fibrin, and increased PT. What is the appropriate treatment for this patient's suspected condition? Is it administering heparin? Is it draining the abscess? Is it platelet transfusion, or is it cryoprecipitate transfusion? So as we know, the treatment has to be treat the underlying cause as the rule number 1. So the answer would be drain the abscess. The definitive treatment is treating the underlying cause. In this case, the intra-abdominal abscess needs to be drained. Specifically in those patients who are not actively bleeding, they can receive prophylactic anticoagulation with heparin or low molecular weight heparin. However, our patient in this question has hematemesis and melena, so cannot be offered heparin as a choice. As far as platelet transfusions are concerned, we understand that should be considered in people with platelets less than 50,000 who are actively hemorrhaging, and 10,000 to 20,000 platelets for those who are not actively bleeding, just at the high risk of future bleeding. So this patient's platelet count stands at 70,000. So not in an emergency need of any platelet transfusion. Next question, again, very much similar in its essence to the previous question. A 35-year-old woman presents with increased bruising. On exam, she is noted to have extensive ecchymosis. Lab testing shows a markedly elevated INR and activated partial thromboplastin time. Platelet counts of 15,000, so INR is elevated. APTT is elevated. Platelet count is decreased. And the fibrinogen level of 35 decreased. Hematocrit level of 21, so anemia is also there. By the way, hematocrit is HB into 3. This is the rough equation. So that means from hematocrit, you can say that safely that hemoglobin is close to 7. Total white count is only 2,000. Rare blasts are noted on the blood smear. So what is the next step in the management of this patient? Limit the blood products to avoid perpetuating the cycle of thrombosis. Order a FISH testing for the 15-17 translocation. Start chemotherapy with 7+3 regime. Start all trans-retinoic acid therapy. Start arsenic therapy. Most likely our patient has acute promyelocytic leukemia. Given her presentation with low WBCs, blasts, and coagulopathy. So, as I just discussed with you, the treatment, the initial treatment of DIC is to treat the underlying cause. So, whenever in a question, don't be led by the random options. When you know the basic, the DIC in step number 1 is to treat the underlying cause. If the patient is actively bleeding, then think about giving them FFPs, think about giving them cryoprecipitate, and also platelet transfusion if they are actively bleeding around platelet counts of less than 50,000. All right. Next question. A hematologist is asked to consult on a thrombocytopenic 23-year-old woman who's 38 weeks pregnant. She has elevated results on liver function tests, low platelets, elevated D-dimer, and presence of schistocytes on her blood smear. Hepatitis testing and ammonia levels are normal. So what we have here is a thrombocytopenic patient, low platelets, distorted liver functions, increased D-dimer, which is a suggestive of fibrinolysis, and presence of schistocytes. That means microangiopathy. What is the most appropriate diagnosis and treatment of this patient? Acute fatty liver of pregnancy and immediate delivery. I don't know why this option can be there, because we are here looking at a picture which is about microangiopathy. Acute fatty liver of pregnancy and infusion of recombinant dehydroxyacyl-CoA dehydrogenase before delivery. Amniotic fluid embolism and immediate delivery. Yes, amniotic fluid embolism can cause a DIC-like picture, but why would liver tests be deranged? HELP syndrome and immediate delivery. Hemolysis is indicated by presence of schistocytes. Elevated liver enzyme levels and low platelet counts is HELP syndrome of PIH. HELP syndrome and stabilization of the patient with plasma exchange before delivery. No. So the patient needs immediate surgery, immediate delivery. So this is a HELP syndrome. In most cases of any coagulopathy in pregnancy, early delivery is almost the best treatment. 2 DIC syndromes are seen in pregnancy. One is acute fatty liver. DIC syndromes with elevated LFTs. One is acute fatty liver, where there is frank liver failure with hypoglycemia and elevated ammonia levels and Then there is HELP syndrome, in which liver failure is not seen, but DIC and coagulopathy are seen. For HELP syndrome that persists or worsens after delivery, then you can opt for plasma exchange and steroids, which can then be of benefit. What is the most appropriate initial treatment regime in a patient with disseminated intravascular coagulation secondary to bacterial sepsis with a platelet count of 60,000 per microliter? Broad spectrum antibiotics, surgical exploration, immediate packed red blood cell transfusion, immediate platelet transfusion. So, patient has been told to have DIC secondary to sepsis. So, the rule of thumb is treat the underlying cause. So, here it is sepsis. So, I would like to treat this patient with broad spectrum antibiotics. That is the answer number 1.